remind myself of what text we're using right now. But the content, I went through the chapter and so we're going to get to fluid restoration, replacing my fluid. So why don't we give IV fluids? Well, we've been talking about it. I don't have enough fluid, I'm dehydrated, so I get some fluid. I don't have enough electrolytes, and so I'm low on sodium, so now I'm going to get fluids. Now the low on sodium, that's a little tricky, isn't it? Because if I'm low on sodium because of the increased fluid, are you going to expect to see fluids given? No. We're on fluid restriction. Administer meds. So anytime I give IV medicines, it's the most immediate response. Obtain blood samples. Nice way to get that. To provide some calories and to administer blood are all reasons for IV fluids. Infusion therapy. We deliver it in solutions by parenteral route. It's the most common. It is invasive. But they have infusion therapy out in the community now. I find that absolutely astonishing. But when I did home health for Boone, about 2009, 2010, my dad moved in with me. I worked at Boone Home Health, and we had vancomycin. A man was doing his own vancomycin out in the community. You know, LPNs can't do vancomycin in the hospital, and they let this man do vancomycin out in the community. I still am just flabbergasted. Okay, you go to a large hospital, and you'll have an IV team, and that's what they do at the university. For a while, we got to hook up some of our students, and they got to go with the IV team, and they went from unit to unit to unit to unit, and that's what they did. They changed IV bags, they changed tubing, they started IVs. That's what they did. Full-time job, a team of them. Okay. That doesn't happen in smaller hospitals, but know that is available in some larger facilities. And universities and trauma one centers. Types of IV infusions. Peripheral. So, everybody, you did an IV start last semester. How long is that catheter for the IV? Your peripheral IV. With peripheral, so down on the hands, lower arms. How long is that? When you pull the catheter, you put it in the person, you pull the needle out. Okay, we got a finger. Is it the full finger? It's about an inch. It's not very long. So that's why we have it in peripheral vessels, because our peripheral vessels aren't very big. And then when you're elderly, they get even more frail and small. Okay? Kiddos, same thing. Central lines. Where do we use the subclavian. We use a carotid. You won't see femoral unless you've got trauma up above, and they have to use it. They need a central line. They have to have it. They'll use a femoral, or they're having trouble with but it's not unusual to see carotids on some folk at the university. I think here, locally, we see more subclavians. Very, very, very common. Or peripherally inserted, PICC line, peripherally inserted central line. Wow! 24 inches! Very different than the peripheral line. The little plastic just goes in about an inch under our skin into the vessel. Central line, we're we're talking about, it's threaded here, it feeds into the subclavian. It's very long. Now, so our care is going to be different. Our flush is going to be larger to flush the tube of a peripheral, of a central versus a peripheral. Harder to flush 24 inches than an inch. And then blood and blood components. You really get that in your senior semester with ICUs and then with drug therapy. Tonicity. We've been talking about osmolarity and our normal body osmolarity. So when we're talking about tonicity of solutions, we're talking about IVs and we're talking about the particle concentration in the IV. Just like we talk about the particle concentration in our bloodstream. We have a particle concentration of the IVs. So you need to be familiar between hypertonic. Now, we're considered isotonic. 274, 294, about 300 year 250. So we're considered isotonic. So if I give an IV that has greater particles than my blood, that's called hypertonic. If it's the same general range of particle concentration as my blood, that's called isotonic. If there's a less concentration of particles in the IV than my blood, then that's called hypotonic. Tonicity. Well, if I'm giving the same particle concentration as my blood, I just said that, versus greater tonicity versus less tonicity. Recall the compartments. ECF is vascular, interstitial. ICF only refers to the cells. Okay. IV solutions. So, normal osmolarity of adults, about 270 to about 300. Isotonic, 270 to about 300. Hypertonic, greater than 300. Now, can you have degrees of tonicity? Can you have degrees of tonicity? How can you have degrees of tonicity? Yes, you can. So you can have a little bit of a hypertonic solution, and you can have a really, really big hypertonic. If it's greater than 300, I might have fluids that have a 400 tonicity, and I might have TPN that has what kind of tonicity? 2400 tonicity. That's a big difference in tonicity. Let's see what. So if I have a 3, that's not bad. If I have a 350 tonicity, it's still hypertonic. But if I have TPN with a 2500 tonicity, that's really, really, really tonic. So it depends on, usually it depends on sugar, glucose, how much glucose is in there. Glucose really adds a lot of tonicity. So, greater concentration of particles in the blood. Now, it's going to cause a shift. Why? We're getting back to homeostasis. Our body's going to have an equalized particle concentration. That's homeostasis. So, in a compartment, you have diffusion, particles spread out. When you have two different compartments with a semipermeable membrane, like in the cell, outside the cell, in your blood vessels, outside the blood vessels, interstitial, we're going to have a osmosis to a greater area concentration of particles. All for homeostasis. All for homeostasis. Hypotonic. An example would be just drinking water. Hypotonic. Okay. So less than 270. There's some kind of borderlines, like your dextrose 5% is really kind of borderline. Most of our textbooks put it in isotonic, but there are some that kind of label it hypotonic. Less concentration of particles than the blood. So again, there's going to be a shift. Anytime there's a difference of particle concentration than our blood, there's going to be a shift. So, isotonic solution examples. D5, it's very borderline. I think it's like 272 or 274. It's just barely isotonic, but it's listed in our text as isotonic. Now, if I take a barely isotonic and I throw in a fourth NS, just a pinch of sodium chloride, then I still get isotonic. here's lactate. You may hear LR, lactated ringers. That is an isotonic solution. Let's look at some examples of, with isotonic solutions, water does not move in or out of the body's cells, okay, or compartments. You have a risk for overload, especially in elder adults. So we know with kiddos and elders, they're more at risk for excess fluid. Hypertonic solution. It corrects fluid, electrolyte, acid-base imbalances by moving water out of the cells into the bloodstream. Parental nutrition is an example. Hypotonic solution. A lot of times with TPN, it's so hypertonic we have to put it in a subclavian or carotid vessel. It depends on the person's needs, but it may be 30% glucose. That's a lot of calories. So we couldn't run, years ago, we had a 10% glucose solution. It was called partial parental nutrition, and we could run that in a peripheral. That's been gone for ages. If they need that much nutrition, they'll put them on a central line. They'll have a central line inserted, and they'll run TPN, co-parental nutrition. Here are some examples of hypertonic. Now you notice D5 was isotonic. If you just double the dextrose, it's now a mildly hypertonic solution. You double it, and you get it up to 50, because now we are looking at TPN at that. Those are all hypertonic solutions. But the tonicity is going to be increasing, isn't it? Because there's more particles. If I have D5, which is isotonic, and NS, which is isotonic, if I put them together, it turns out to be a hypertonic, because now I have enough particles. D10 NS. LR is isotonic, D5 is isotonic. If you put them together, now we got a hypertonic. D10 LR. D5 a half NS. Another example of a hypertonic, but not nearly as hypertonic as the D50. We've got degrees of tonicity. Where do you find out what the tonicity is? Well, you're going to learn 4 common ones and just know it. But where can you get that information? On the back. It's right on the back. It's usually about the 4th line down. We used to take time in clinical when the student had an IV, and it's like, what's the tonicity? Read the back. Let's see what it says. Hypotonic solution moves water into the cells and expands them. Okay, so hypotonic solution. So here's my not yet. We'll get to that. Sorry. Pause. We'll talk about that later. Your hypotonic solutions, Normasol M. I don't see that around very much. I see a half an S. That's probably the more common one. There is 2.5, half an S, but half an S is probably the more common hypotonic solution. Now these are the ones you need to know. These are the common ones we see in the clinical setting. You need to be familiar with these for testing. D5W, NS, D5 half NS, and LR. Okay. So, what's in each of these IVs? The label tells you what's in it. D always stands for dextrose. The number 5 tells you the percentage. Is it a D5, 5%, D10, 10%, D20, and so on. Okay. So, the most common one we use is a D5, 5% dextrose. A half an S, so there's sodium and chloride. So dextrose, sodium, chloride, and water. That's the only thing in D5, a half an S. D5W. The only thing this is how to calculate. Actually, if you just remember D5 is about 200 calories. This tells you how to calculate it. 5% is 50 grams. You have a liter. Anytime we're talking about an IV, we automatically talk about a liter. That's a bag. Otherwise, I need to specify. Is it a 500? Is it a 50 bag? Is it 100 mLs? That's what you see your IV, your antibiotics in. Okay. So it's 50 grams. Remember that a carb is 4 calories. So 50 grams times 4 is about 200 calories in a bag of D5. So if they get 10 bags, they get 2,000 calories. So normal saline, the only thing in there is sodium chloride and water. Lactated ringers, wow, this is chock full. This is worth remembering. Look at what that's in there. Sodium, and you get 130 milliequivalents. That's kind of getting close to what we normally need in our bloodstream. The potassium, it's 4 milliequivalents. That's pretty close to what we normally have in our bloodstream. Our calcium, it's milliequivalents, not milligrams percent. So it's 3. Again, nice replacement. Your chloride, 109. That's close to normal. And then it gives you lactate. It's metabolized into a bicarbonate. That means it helps with mild acidosis. It helps with mild acidosis. With dialysis, they used to use lactate in their solutions to neutralize the acids. Now they just use bicarbonate. But for a long time, they used to have lactate. Lactate is converted into a bicarbonate to help neutralize too many acids. Remember, if the osmolarity is greater than 600, it needs to be in a central line. That's why your TPN is always in the central line, because of the high osmolarity. Our peripheral vessels just can't tolerate that kind of pressure. They just can't. TPN has an osmolarity greater than 1400. We're talking about a normal body osmolarity of 300. That's significantly different. TPN should never be infused in peripheral to damage blood vessels. The other thing too with TPN, because of the heavy glucose load, what problem might come up? What's a standard care when people are on TPN? You may not know this. It's okay. That's why we're talking about it. Hyperglycemia. Because my pancreas may not be able to respond sufficiently. Are they going to become diabetic? Is that what that means? No. It means that they're taking in so much glucose that their pancreas can't produce enough insulin. And so we will do blood sugar checks 4 times a day on anyone on TPN. And if it's out of bounds, then we will give them insulin, a sliding scale, just to help with that temporary load. As they heal up, when they don't need TPN anymore, they won't be diabetic. If they already were diabetic, it's even more trickier. But it's just because of the glucose load. So if we have a liter bag of D5, how many calories does it have in 1 liter of D5? About 200. So if you have TPN, and let's say it's D50, how many calories in that liter bag? 2,000. That's 2,000 calories. Exactly. Right. Because of the glucose. IV meds give safely, rapid therapeutic effect. Has anybody given some IV meds? Did you you do that last semester? Give an IV med in a clinical setting? But you will be doing that. We have IV med books. You don't want to use your regular med book. You want to use an IV med book. Okay? That will give you do I need to dilute it or not? Typically our H blocker meds, our Pepsids, they have to be diluted in 10 mLs, okay, before I can give it. So we always look at, is it diluted, over what rate I give it, over how many minutes, so I have to calculate that out.
So when it needs to be diluted, is that when they do the piggyback thing?
I'm sorry.
If it needs to be diluted, is that when they do the piggyback thing?
No, this would be an example of, I have a peripheral IV, and the doctor has ordered. Now remember, why are they put on H blockers when they come into the hospital? We talked about this. Stress. Because of my illness, stress, my injury, I produce cortisol. Cortisol triggers what in my stomach? Hydrochloric acid production. I can wind up with a GI bleed, a GI ulcer. Okay. To prevent that, they do H blocker medicine, hydrogen ion blockers. That's your Prevacid, your Pepsids, your Rimidine. Okay. So typically, when you read the directions, those have to be in an IV syringe. That has to be diluted with 10 mLs, and I'm going to give it in my peripheral IV. We will do that, part of our college lab. If it's an IV antibiotic, it's already diluted in either 50 or 100. Some meds have to be like our vancomycins. We used to dilute it in 500. For a number of years now, I noticed they dilute it in 250 mLs. And then you give it over the prescribed rate of flow. Vancomycin is one of those meds you give too fast. You know the bad things that can happen? Anybody know bad things that can happen if you give red man syndrome. They get very flushed, they get hypertensive, they can have a cardiac arrest. We need to read. We need to read before we give a med so that we know we're doing it safely. You should be doing the med only with your instructor, or if she releases you to go with the nurse to do an IV push. IV site selection, accessibility of the vein. We don't want it under their armpit, do we? No. Okay. Start distal and work up. Why do we start with distal? Because if I have a vessel up here and I puncture it and then I go down here, it's going to leak. Distal, work up. Distal, work up. How accessible is it? General condition of the vessel. Is it rolling? Is it difficult to find? Okay. We want our peripheral, when we put on a tourniquet, you want to palpate, you want those superficial ones you can feel. How long is the IV going to last? Okay. It's going to be a number of days. Their age. Okay. So for neonates, where do they put in IVs? You haven't had each yet, but are you rubbing here on purpose? Scalp. Scalp with neonates. What about toddlers? Their feet. That's harder to reach. Okay. What about adults? Our arms. Hands, lower arms. Why not the feet in adults? There's a rationale. What? Thrombus. Clots. More clots. So, I have on occasion seen it when there's so much trauma that they have a femoral line or they have an IV in their legs because there's trauma in their arms and upper chest and it's difficult. But they don't use the feet because there's more thrombus, more emboli that forms because our circulation is decreased. Size of the IV catheter, remember the smaller the bore, the larger the catheter. And then the kind of solution. We have solutions that are very irritating. Potassium replacement actually can, cause stinging and burning. So it needs to be well diluted and run slowly. So some are vancomycins, hard on vessels. So the kind of solution makes a difference too. And then here's some examples. I was always at the university, there'd be a hard stick. Now, you get a chance to stick your patients. It has to be with the nurse's permission. Sometimes the patient will refuse. With students at the university, I gave you one shot. They're not going to be pin cushion. You get one shot. And we'd have a number of students who would get in. But sometimes we have some very difficult sticks. If they come in dehydrated, it's going to be hard to find. Okay. You'll get to the point, though, if you get on an elevator or you're out in public and you see somebody's ropey vessels, you're like, I only had a catheter right now. I could get that vessel. You got wonderful vessels. Okay. You'll pay attention to that. Let's see. I don't know where I was going. With the IV team, it was amazing. We'd have the nurses on the unit that are very experienced, and they wouldn't be able to get it, and they'd bring the IV team in. And my impression is it was like they'd do and get it. It's like, oh my, look, how did you find a vessel there? They were just, it was very impressive to me. It was amazing. Okay, vascular access devices. So we have devices to access the bloodstream, the vascular vet. We've got the peripheral, we have the central. What did I do? I already did that. Oh, okay. One of the things I want to talk about is with our peripherally inserted, we have at least 10 ml flush. You need to find out what the standard flush is. It used to be, they've changed it over time. So I want to say peripheral is 5 and a PICC line 10 to 20. Okay. So double check that. When you do orientation, you be sure in both of your groups to find out what's your normal flush at St. Mary's for a peripheral IV versus a central line. Okay? It's an important question. Now, anytime that we have a saline lock and we give a med, you flush first, you give the med, you flush again, and you lock it off. Why do you flush first? Make sure it's patent, which is AKA open. Make sure the line hasn't clotted off. How do we prevent lines, PICC lines, or peripheral lines from clotting off, or saline lines? How do we prevent that? Routine flushes. We were in the clinical setting, and I had one of the supervisors say, we've had some lines clotting off, and it's like, I can tell you, it is not us. I am a very faithful flusher. If they have dual ports, you flush both, even though they may not be used right now. Otherwise, they're going to clot off. You're going to lose your multiple ports or single port. And they have to go in and restart. Regular flushing, typically 2 to 3 times a day. Routine flushing, every port. If you've given an IV, you've already done that flush. You don't have to reflush. But that's how you maintain, that's our job, nurse's job, to maintain those saline locks or those locked off ports. Now remember, the flush is at the same rate that we give the IV. Okay, so we already talked about the forearm and the hands. Why don't we take a break? We'll come back to IVs.